Good afternoon. Thank you for coming. Welcome to the Midday Symposium. This is sponsored by Olea Medical. My name is Adam Davis, and I am the Chief Medical Officer at Olea Medical. I think we have a very interesting program today. We will be discussing technological trends that are currently impacting and will continue to impact radiology and medical imaging in the future. We will specifically be speaking about display, visualization, automation, and artificial intelligence. I am thrilled to be able to present two speakers today. Dr. Peter Chang, who is the Director of Artificial Intelligence and Diagnostic Medicine at the University of California in Irvine. He is both a software engineer and a radiologist and has received numerous awards and accolades for his work in artificial intelligence. Our second speaker, Dr. Christian Herweh, is from the University of Heidelberg. He is within the Department of Neuroradiology and is an interventional neuroradiologist specializing in stroke and particularly within automation and artificial intelligence within cerebrovascular disease, and he is involved in numerous technologies within this area. I am a neuroradiologist, a practicing neuroradiologist, and I am formerly a clinical assistant professor at the New York University Medical Center, where I was director of the imaging labs. And I have been involved in display and visualization and other technologies within radiology for approximately 15 years. Currently the Chief Medical Officer at Olea Medical, as well as the manager of a technology display company, Amalgamated Vision. So let's get started. I'd like to give you an introduction to the trends that are impacting radiology, and I think these are the major trends, in my opinion, that are currently evolving. And I've broken them into three separate groups because they tend to fall that way and to be related that way. The first is display, which has a hardware component and a software component. The second is computer-aided automation, radiomics, artificial intelligence, big data analysis, data mining. And they tend to fall together because they're all computer-related specialties that feed off each other. The third major category is MRI and CT design. Much of it has to do with improvement in quality and reduction in radiation dose. For the purposes of this talk, we will really only be speaking about three of these technologies: display, automation, and artificial intelligence. So let's start off with display, and it's important to remember that visualization in medical imaging has two separate components. There's the content, which is software-driven, and the display, which is hardware-driven. Most of the more advanced imaging has to do with head-mounted display or eyewear, and the experience that we discuss is virtual, augmented, and mixed reality, as well as smart glass experience. For those in the audience not familiar with this, virtual reality is a computer-simulated experience, and it usually takes place within a headset or a virtual reality room. And this is an immersive experience. The user is brought into the entire reality of that simulation. Within virtual reality, you'll often hear people discuss the word presence, and presence is that feeling of reality as you use virtual reality. The subset of virtual reality is augmented or mixed reality, and this is a form of VR, virtual reality, in which the computer layers information or data onto the real-world environment. So for brevity, we often use the word XR. XR refers to the entire spectrum of virtual, augmented, and mixed reality. So we'll continue with definitions. There are two broad categories that people are using virtual reality in medicine currently. And the first is to convey, to give data, to give information to the practitioner. The second is as a medium to treat disease, and this is used in health and wellness. And it's very prevalent now in the fields of psychology and psychiatry, where people are using virtual reality to treat post-traumatic stress disorder and anxiety and other psychopathologies. For the purpose of this lecture, we'll really be discussing XR in terms of data given to the user to convey data in a real-time medical practice. Now, within XR, we have the content, what we are looking at. As radiologists, we are very familiar with the first, and that is DICOM, radiographic data sets that we utilize. But from a visual perspective, there are really three components of the DICOM. And the first is shape, usually that's the organ or structure, spatial relationships, relative position, and scalar aspects, such as the signal intensity or the Hounsfield units. Two other forms of content that we come across are data, which is just simply characters, icons, and illustration or graphics, and that's often used for medical education. So within the hardware, there are numerous head-mounted displays that we can use for virtual reality, for augmented reality, and for the more smart glass-oriented experience. This is the I have some videos to help explain some of this. This is probably what you're most familiar with, and this is virtual reality for radiology training. Now, this is interactive. I'm controlling this from a web-based virtual reality portal, and what we see here is Dr. Haskell is performing a TIPS procedure. This is filmed in a 360 virtual reality format, and the user can look around the room as he's doing this procedure. This is not the video. This is me looking around the room from this previously recorded segment using virtual reality headset. And you can zoom in and look and see what he's doing. And that's really what the format that most people are familiar with. The second format is using virtual reality for education. I think I'm going to have to bring down that volume because there's some... or we'll listen to the music. And so this is using virtual reality with graphics. And again, this is user dependent, and you can select the categories you want to be in. These are segmented illustrations. You can move around the object, and you have that feeling of reality with the anatomy that you are working with. But that really doesn't impact what radiologists do. And this is closer to our field. This is virtual reality for an imaging review. And this is somebody in a virtual reality headset using a clip plane moving through a volumetric rendering of a radiology data set. And it's very similar to what you would do on a 2D monitor, except this is three-dimensional and immersive. And we can see now he's using a clip plane to move through multiplanar reformats, exactly as you would do on a screen, but in 3 dimensions and interactive. We can also take this a step further. Just like any radiology workstation, all of those tools are present for the user, so we can change the lighting. And in here, they've used the simulation of a OR lighting fixture, which you can move around the room and provide lighting. And this provides a really deep understanding of the spatial characteristics, not only for the radiologist, but for the referring physicians. So you might think this is all well and good, but it's not really what I do for a living. So this is a video of work that is being presented next week. That hasn't been published, and I reviewed this for the user interface meeting that's taking place in Berlin. And this is a virtual reality reading room. This is a work in progress, and a radiologist reviewing films with a virtual reality headset. And what this study is doing is looking at the different ways in which you can interact with it, with direct controls or indirect controls. But it's interesting to notice is that this is the simulation of a PACS environment within a single headset. And once you have resolution worked out and clarity and all the controls, this can really substitute for what you are currently using in a PACS environment. This is the last of the videos, and this shows an augmented reality experience. And what this is a T1 weighted MP range post-contrast. This volumetric data set is co-registered to the patient, and using tools, clip planes, we can move through that volumetric data set. This is live in the OR. And surgeons are using this to help with surgical planning. Obviously, it helps with the craniotomy to see where the tumor is in relation to the overlying veins at the cortical surface. And this is something that is happening now. It is something you need to be familiar with, because I seriously doubt that surgeons will not be using this routinely within 2 years. This will be ubiquitous in ORs, and it's something really that you should become familiar with. So this is the hardware. These are the paradigms we're looking at. But to really get deeper into it from an imaging perspective, you need to understand what is driving this. What is the visual properties that makes this so worthwhile? And it really has to do with spatial relationships and depth. And the first is monocular depth cues, and we're familiar with that. It's what we use on workstations right now. It gives you the illusion of depth, perspective, occlusion, shading, all the things that help you think that a 2D format is actually 3D. But there's the element of stereoscopy, and what stereoscopy is exactly what you use in everyday life to see. A visualized object is projected on two different aspects of the retina, and that difference in perspective between the two eyes is what your brain interprets as depth. And stereoscopy is the single most important visual depth cue up to 2 meters. And it's basically two images, slightly different orientation in your brain. It's combined into a single image. So stereoscopy has been around forever, at least 6 decades of utilization in medicine as well as within industry. And what stereoscopy has been shown is to increase selective attention, better differentiation and identification of complex spatial relationships, improve memory retention, better manual tasks, as well as a greater impact on novices, especially for complex tasks. The other interesting thing is that stereoscopy correlates with that feeling of reality within virtual reality. They're one in the same. So how do we bring this together? And we bring it together with volumetric rendering. It's the content that brings all of this together. So we have to remember that all modern medical imaging uses volumetric acquisition to capture an entire 3D data set. And that makes it a natural source for virtual reality, for stereoscopy. Radiologists only use 2D because it's a facilitator. It makes it easy to read, it makes it fast to read, it helps you with your throughput. But that same information in a volumetric rendering is the same as in 2D. They have the same inherent information. But using these new displays, we can exploit this. So let's take a look at that volumetric rendering. It's really the product of a software engineer's idea of what things should look like. Simulated rays of light through a 3D volume, the interaction with the voxels, and the tools that you use to look at that volume. The information that you extract from that data set is entirely dependent on that software reconstruction. And the quality of that software reconstruction is what affects your XR experience. So how are we doing with this? Well, actually, imaging has now become, the reconstruction of imaging has now become the weak link in the imaging chain. This is a volume rendered image. This is produced by the same manufacturer, 2 different versions of their software, and you can see the quality difference. The image on the left with the topographic lines and the high definition, the image on the right, much less so, blurry margins, not well defined. Exact same data set, just 2 different workstations. We can see an endoluminal view on the right, and on the left and on the right. The data quality is so poorly reconstructed that we don't have that luminal view. So what about our reconstruction affects this? Why do we have this dilemma? And the reason is because currently we use ray casting. That is our traditional rendering technique in medicine. It's a single ray of light that moves through that 3D volume and is projected onto a 2D surface. But there are better ways of doing this, and this has been used in the cinema industry for years for animation. And instead of a single ray of light, they simulate the more complex interactions of light on a computer through a volume. The reflections, the refraction, those secondary aspects of light, which gives depth and shading and a more photorealistic appearance. This is the traditional path raycasting, and the second, more recursive, path tracing. Single ray of light versus multiple rays of light, simulating that. So I need to remind people, this is not a photograph. This is a computer simulation using path tracing. And this is a photorealistic volume that we are looking at. This is an MRI of the brain. This is a DTI of the brain. This is a CT of the head. This is a CT of a trauma patient, and that's an iliac CTA runoff. And these have a photorealistic, natural appearance, and it only has to do with that reconstruction paradigm. Pericallosal aneurysm on a CTA on the left with path tracing, on the right with traditional raycasting. Tremendous difference between the two. This is the quality of content that you really need to drive that display. So that's a quick review of display and visualization of where we are and where we can be and what's about to happen within the next 1 to 2 years. The other aspect that I'd like to discuss and will be further elucidated by our speakers is automation. And again, I'd like to start with a definition. Automation is the technology of performing a process, a procedure, without human assistance. And this is assisted by artificial intelligence, but simple automation itself can really change a radiologist's workflow. And there are many aspects of automation that we use in our daily practice. So as a neuroradiologist, I just simply want to bring out two aspects of automation that I find incredibly important. And the first is when doing CT perfusion. So this is the traditional way of moving through CT perfusion. Manually, you select an area of arterial input function, and it gives you that global determination. One single point determines the AIF for the entire brain. But what happens if using automation, we can move through the same volume and select multiple AIFs and bring them together to create a local AIF, which brings that arterial input function closer to the parenchyma. And here we see this is done automatically within oleosphere in order to give you a local AIF. Does this automation make a difference? It certainly does. This is the infarct is determined by DWI. This is the infarct is determined using that local AIF, multiple arterial input functions. And this is that same prediction with the global. Obviously, a significantly more accurate determination using automation and multiple arterial input functions to predict the size of that infarct. The second automation that I use routinely is automated CT perfusion maps. And this was a study done by a colleague of mine, Dr. Decker-Ghani. And what this paper showed is that automated CT threshold perfusion maps, having a computer determine what is falling within the threshold of infarction and penumbra, significantly outperforms the interpretation by a radiologist. Now, I had been reading CT perfusion for years, and this was difficult for me to accept, but the computer consistently outperforms me when trying to determine the area of infarct and penumbra. And the other benefit is that this can be performed 24/7. The computer is always available for that stroke patient at all hours of the day. This is the qualitative maps that we're used to reading on our own. These are the threshold maps, which show you the areas really well delineated, red infarct and the yellow in penumbra. We can take it a step further, and with the automation, we can give different flavors of those thresholds, because there is no exact threshold, as we know, but there is certainly a gradation. So we can ask the automation to show us what would be different if we slightly changed the Tmax. How would that affect our area of infarct? We can use automation to introduce a temporal component. And what we're looking at here is the simulation of flow within that area of infarction. And that gives us different information. It gives us insight into what we're looking at. And then, because it's automated, we can put the entire thing on your smartphone. It's the natural extension of this is artificial intelligence. It's really what powers much of this automation. And this will be spoken about in detail by the next two speakers, but for the audience and for myself, I'd like to bring up some definitions for orientation. Artificial intelligence is straight up intelligence demonstrated by a machine. As simple as that, as opposed to natural intelligence, which human beings demonstrate. You can think of it as machinery imitating the cognitive functions that are typically associated with the human mind. There's general artificial intelligence, which is machinery really mimicking or accomplishing any cognitive task that a human could. And that general AI is many years away. But current AI is not. Current AI is being used, and this is a more task-specific and goal-limited artificial intelligence. And it really is quite good at what it does. So you might think, well, that's okay. It's task-limited. It's goal-specific. It's very simple. But you should note well that within this definition, the job of a radiologist, pathologist, a dermatologist are all task-specific and goal-limited. And all of these aspects of visual interpretation are amenable to artificial intelligence. So AI has been around for quite a long time. This is a paper, 1994, by Charles Kahn, and he very astutely comments that expertise is easier to model because it's specialized and focuses on a narrow class of problems. So you might ask yourself, well, this is 1994. Why am I only hearing about AI in 2017 and 2018? And the reason is because things have changed a bit. There's been an increased effort, increased resources dedicated to designing and optimizing artificial intelligence. We now have better computing power and better data storage. Importantly, it's the nature of the way we function in radiology. We now have massive amounts of digital imaging data, and they're organized in well-organized medical databases that we can access. And this is important because we can use this information to train the AI algorithms. Finally, it's the nature of what we do. Visual tasks are very well suited to being accomplished by artificial intelligence. So let's take a quick look. Task-specific, goal-oriented AI. Basically, AI and its subset deep learning, which Dr. Chang will speak about, recognizes complex patterns and discriminative elements within large amounts of data. And it distills them into a quantitative assessment, as opposed to what radiologists do, which is distill it into a qualitative assessment. This quantitative assessment gives you improved accuracy and better reproducibility. And what we see here is AI recognition of areas of hemorrhage, as well as area of infarction and mass effect within the brain. It's not only image analysis that we're looking at. That's what we speak about the most, and that's what's most obvious within the press. But AI will impact every aspect of radiology practice: operational workflow, study acquisition, image pre-processing and image quality, reporting, as well as the integration of that radiology report with the clinical tests and with the other clinical services. And this is a nice example of using AI to improve image quality. You can eliminate artifacts, suppress noise, correct motion, and reconstruct sparse data. What we have on the top is the original images. And on the bottom, what we have is a high-resolution product produced utilizing artificial intelligence means. Artificial intelligence has a notion of what the image should look like, just like a radiologist does. And just as a radiologist reads through the noise or reads through the artifact, AI can do the same thing. By having a notion of what it is, it uses its experience, its previous studies that it's seen, and it predicts what it should best look like. So where are we with AI? I think right now AI can be thought of as the radiology assistant. What will happen in a decade, I simply can't predict. But I think it's reasonable to assume for the next decade the emergence of AI in a task-specific way, enabling radiologists to detect and interpret pathology, as well as to make the determination of normal much more quickly and more confidently. And I think the impact on that will be, as radiology economics demand increased numbers of studies and increased throughput, radiologists will be using AI to move through these cases in a more efficient and a more confident manner to make these diagnoses. I think the impact is best summed up on a quote that I obtained in the literature and from Dr. Liu at Massachusetts General. Artificial intelligence won't necessarily replace radiologists, but it will replace radiologists who don't use artificial intelligence. And that's a nice way of thinking about it. So thank you very much. I'd like to...
So I think that's a great transition, actually, Adam. That was an excellent talk. And out of all those emerging and fascinating technologies that we see on the horizon, what I'm going to do in the next 15 minutes is focus very specifically on this idea of artificial intelligence, trying to highlight the types of opportunities that we might expect, and to show you a few examples of some applications that actually Adam already started to touch on, so it's perfect. As my disclosures here, of course, our close relationship with Olea Medical and the company that was referenced a few times here, trying to develop a little bit of AI for various tools. I will say as a background, so I'm a physician by training. I'm a neuroradiologist. I've also worked in actually personally developing and coding these very specific AI deep learning algorithms for the past 4 or 5 years. So I'm going to try to come at it with a little different perspective, trying to understand both technically what's possible with this technology, and then clinically, which type of applications make the most sense given what we know AI can do today. All right, so I'll start out here by saying that it really goes without much additional mention that AI is really starting to explode in many fields outside of medicine. Right, so we're thinking about things like self-driving cars at Google, things like facial recognition, or mastering the game of Go down here. I don't know if you guys noticed this in nature. That game has more number of moves than the number of atoms in the entire universe. All right, so this is an extraordinarily difficult task and something that we're just beginning to conquer and understand. Now, because we hear about this so often in the media, it's oftentimes easy to forget that AI has been around for decades. Right? We've seen this for 40 or 50 years, but really in the past 4 or 5 years, we're starting to do these type of things. We're seeing the revolution, right? And it's because of a very specific type of AI that's come into popularity, known as deep learning or neural networks. So let me talk a little bit about what that is. For those that are a little more technical minded out there that have written code in the past, what we see here is that compared to very traditional types of AI, which would require me as a programmer to come up with rules and logic and if-then statements, you need essentially one rule for every exception you can think about. So as you can imagine, this becomes extraordinarily difficult. That is in stark contrast to deep learning, which all I need to do as an engineer is to create a virtual brain, a literal network of neurons, and simply give it the flexibility and the capacity to rearrange its connections, strengthen some and weaken some, just like the regular biologic human brain will work. And that's it. I don't have to give it any other information. Naturally, through that process, intelligent behavior emerges. So it's kind of mysterious, but it's also extremely fascinating and very powerful. Now, for a less technical explanation, I'll credit my colleague in the audience for this one. Take, for example, trying to teach a kid what is a dog, right? Dogs have all sorts of shapes and colors and possible appearances, but a traditional AI technique would try to go through and break each feature down into very specific tangible blocks. So looking for a tail or paws or fur or nose. And through the synthesis of these different features, you would eventually come to the conclusion that, aha, what I'm looking at must be a dog. Deep learning, on the other hand, reverses the entire situation. No longer am I required to go through and break down an image into its specific parts. All I do is simply show the kid or show your learner, this is a dog, and this is another dog. Here's another dog, right? And over time, naturally, that learning is implicit. It's learned through the network and the processing itself, right? So that's really the difference of deep learning. Now, with that in mind, what are the opportunities, right? What can we expect to see from this technology? And the short answer, if you read, is really anything, right? So mathematically, you can prove that a deep learning neural network can learn anything you give it, right? We've shown it can learn random noise, no problem, right? But presently, there are some limitations and some practical considerations for the types of tools that we might expect to see now, today. All right, so what are those considerations? Well, one, the presence of big data, right? So these algorithms in their current state require a lot of data to learn and a lot of data to train successfully. So the types of applications that we might expect to see are those that are very prevalent, right? Things that we see every day in clinical practice. Another is this idea of instinctive interpretation. So what an AI is very good at today, not saying that's the only thing you can do, but what it's very good at today is a problem where the mapping from image to diagnosis is relatively straightforward. It's quick, right? So I could show a trained radiologist a specific slice containing that pathology, and the radiologist can turn around and tell me the diagnosis in a split second, right? It's just pattern recognition. If that's a problem that you have in mind, something that fits that bill, that's something that AI today, without any modification, can solve. Now, what that means is that practically there's a list of possible applications here, and in the following slides, I'll just go over each one of these one by one. All right, so first we have the idea of detection and triage, right? The identification of some urgent or emergent finding for essentially prioritized interpretation by a radiologist. Now, I will say that a lot of these findings in disease processes are quite obvious. They're not difficult for a trained radiologist to find. Nonetheless, as a clinician, these would be extremely powerful and extremely useful for me because it may be an hour or 2 or 3 hours before I have time in my day to find that patient in the stack of films and provide the interpretation that's needed, right? So this still provides quite a bit of value. A good classic example of this is trying to detect the presence of an occlusion in a patient with stroke. So going through the large vessels of the brain and trying to detect which area might actually contain a clot that can be acted upon. What this algorithm can do, for example, is go through and start that process just like a radiologist. So go through and find all the large vessels, in this case here in the MCA cisterns, and scroll through to the point where it actually finds an occlusion, right? Again, as a trained neuroradiologist, this is not a difficult finding to make, right? But as we all know, brain is time. Time is brain. And the earlier that we can make this diagnosis and the quicker we can get this information to our interventionalists and to our neurologists, the faster we can streamline the process, the easier everything becomes. And AI is critical to make these type of things happen. The second category is this idea of quantification, right? So again, many of these findings, for example, a stroke or a hemorrhage or a tumor may be quite obvious to the physician, but it's extraordinarily difficult to try to precisely quantify and measure it in some way, and that's another tremendous opportunity for AI currently. Take, for example, the identification of hemorrhage, right? So this particular tool will, of course, combine the detection part, which we just talked about, go through, look at different areas of the brain and identify possible areas that, in fact, do not contain hemorrhage, so a mimic of hemorrhage, as well as the areas of true hemorrhage here. And then for cases of positive hemorrhage, actually go out and importantly measure the volume. Now, this tool is very accurate, so out of over 10,000 exams, only 20 cases of hemorrhage were missed out of over 900 positive here, and this data set is quite expanded much further than that. But more importantly, into the category of quantification here, the algorithm can go through and identify the volume of hemorrhage that you have, right? The volume of hemorrhage. Now, this is very interesting because currently there's not a real good way for us to do this, right? Even though there are decisions that tend to be made at different volume thresholds, the best thing we have is known as this ABC/2 model, which is where a radiologist will go through and make a few single-dimensional measurements and some calculations behind the scenes. That approach is known to overestimate the true ground truth volume of hemorrhage by over 20%. right, compared to an AI tool now, which is able to quickly go through and make the finding and quantify with just around 2% discrepancy. So very powerful. Of course, brain tumors is another common category for this, right? This is a disease process whereby the initial diagnosis itself may be a dilemma, right? You're trying to figure out the grade of tumor and such, but really on all follow-up exams, all you're interested in is the tumor bigger or smaller or the same. And right now, all of the standard of care, right, is a set of very subjective guidelines put out by Raynaud, where a neuroradiologist will scroll up and down and sort of look at things on multiple planes and say, aha, okay, I think it's probably about the same, or I think it's maybe growing a little bit here. But there's really no simple, reliable way to get these objective measurements. And again, this is somewhere where deep learning AI will shine. I'm not asking the AI to make a complex interpretation. I'm not saying, you have to do anything that difficult. Just mark the pixels on the screen, which are abnormal, and count them all up for me, right? That's something that AI can do very, very well. All right, in terms of the third category here, I have a characterization, which is what I'll define here to be the objective evaluation of some image finding. And this will take a little bit of explanation, right? So what I mean here is that if you think of what a neuroradiologist or radiologist does on an everyday basis, right? What we do is go through an image. We try to determine whether a finding is present, right? So we try to look at a part of the brain and say, is this a little bit too dark or is this a little bit too bright, right? Is this basilar artery a little bit too dense? And based on those findings, and based on maybe the clinical picture, we're going to put everything together and make a final interpretation of what's going on, a synthesis of the different features in the image, right? Now, the first part, whereby we go through and assess whether a finding is present, and assess the degree of that finding, that's something that AI can do extraordinarily well. It can do better than us, right? Sometimes we'll scroll through and we're really just trying to second guess ourselves. Is this just beam hardening? Is this really that dark? That's something that's very subjective and difficult for a human to do, something that AI can handle very well. By contrast, synthesizing all that information together, right? Taking into account the entire clinical context of what's going on in the patient. That's actually something very difficult for an AI to do, and something that we, as humans, are highly skilled and trained at. So this complementary role of AI and the human, I think, is very important to point out. And as an example of this, I'll use stroke, right? Stroke is extraordinarily subjective to evaluate on CT. In fact, many strokes we know as humans just can't be detected on CT, right? Our job on CT is not to look for stroke. We look for the complications that preclude the therapy of stroke, right? So acknowledging that as a baseline, we're not trying to teach an AI to tell me, does this head CT have a stroke or not, right? All I want it to do is go through and objectively evaluate the findings that I as a physician need to know to determine whether or not there's a stroke. Things like the degree of low attenuation, right? Or the degree of mass effect. That's what I'm looking for to determine whether or not there's a stroke. That's something that the AI can do and hand off to me in terms of making that final interpretation. And of course, if done properly, right, you can superimpose things like anatomy to do aspect scoring and things like that. But you're giving the power of that interpretation back to the human radiologist, right, working together. As a last point here, I'll talk a little bit about image post-processing and pre-processing. And here what we're looking for are workflow-related tools that, as Adam already mentioned, improve the overall speed and efficiency of what you're doing. As a very popular example, I'm going to use this idea of deep learning-based image reconstruction, the process essentially of going from case-based raw data on your MRI machine to the image. I will say that this is a very popular and very an area with tremendous opportunity because, number one, there's a very, very objective mapping here. So you have the raw case-based data and you have the images, right? There's no interpretation here. There's no process where a human can go through and subjectively assess something. This is the data. This is what it is, right? And number two, you have a ton of this data. This data is acquired on every single MR scanner, on every single image that you obtain. So this is completely a very easy and a place where AI can really make a big difference. All right. Specifically, what I'll point out to here is that not only are we interested in mapping from case-based to regular images, right? Because that's what math is already solved for us. What we're interested in here is the ability to subsample case-based. Right, so to take an MRI scan of X duration and try to speed it up, get less data, Don't acquire all of K-space and let the deep learning algorithm figure out what that missing K-space should look like and what the denoised or original image on the other side should be. So another tremendous area of opportunity. All right, I think that's it. I think we don't have too much time today, so I'll just quickly summarize what we have. We covered in the beginning this idea of deep learning in the context of AI, and specifically what sets deep learning apart from the types of AI that came before, right? This idea of implicit learning without any real human engineering of features. And given that technology, we highlighted a few of the opportunities, right? There's some things that certainly we might see in 10 or 20 years where an AI acts autonomously and reads images on its own, but we're really not quite there yet. Even from a regulatory perspective, right? If I had that tool today, it would still take me a long time before the required regulatory agents would approve it, and culturally as a society in medicine that we would accept something like that. So here are really the more salient opportunities, things that we can expect to see now or in the very near future. And those involve things like detection, right? Triage, identifying some urgent finding, bumping it up on the list. Things like quantification, so taking a very heterogeneous finding and going through and precisely quantifying how much of it is present. There's things like objective characterization, which again is this idea of using an AI in tandem with a human to tackle an image and to provide a more robust assessment. And these other tools, right, beyond the images, beyond the interpretation, things like pre-processing or post-processing or workflow-related, again, represent another tremendous opportunity. So with that, I will conclude, and I think we have questions at the very end. Is that correct? Right, okay, so we'll do that. Thank you.
So thank you very much to everyone at Olea Medical and Brainomics for giving me the opportunity here to give this presentation. I will try to focus on the clinical aspects and the practical effort that can be taken out of AI applications in acute stroke diagnostics. Okay. These are my disclosures. And as a disclaimer, I would like to say that I try to focus on items which have been proven scientifically, so by and have been reported on scientifically. And I would like to start with a clinical case. This is a patient who has a wake-up stroke, was last seen, well, at 9 o'clock, but presented at the hospital at 2:30. And then the question was raised whether or not to refer her. In this setting, current guidelines recommend perfusion CT image to estimate whether there is salvageable tissue. But this is often enough not possible at primary care centers. So we made the decision anyway to let her come and treat this ICA occlusion. Well, first we had to recanalize the cervical ICA and then did a thrombectomy under proximal balloon guiding occlusion. Got a sufficient recanalization. Patient improved clinically significantly, and there is only a basal ganglia infarction with sparing of the cortical areas. The aspect score, which was introduced 18 years ago, is well known, has been shown to be reliable and a good predictor, so I will skip this. I was skeptical as a radiologist whether a computer could make an aspect score, because this is quite difficult, as we all know. And I was also curious to test it, and that was what we did with a set of patients who had diffusion-weighted MRI very close to the CT scan, so we had a real ground truth. And what we found was that the software called eAspects had a sensitivity and specificity which was equal to that of experts and significantly better to that of radiology beginners. Recently, we also tried whether different CT reconstruction algorithms would have an impact, because different vendors recommend different reconstruction algorithms, and also the customers have different settings in each hospital. And what we did is we had again 43 patients with an M1 occlusion, and had different CT reconstructions of the acute stroke CT, and being read by blinded stroke physicians and by the software again. And what we could show there was that they were all quite similar in performance. So the software, again, was at the level of the experts, but had the most robust performance across different reconstruction algorithms. The next question, of course, is that these results can also be used, whether they can be used for outcome prediction, because for the primary aspect score, this has been shown. So we tested this again with the computed aspect score. And we wanted to know whether it could predict bad outcome, because the philosophy, meanwhile, is not to decide who should be treated by mechanical thrombectomy in case of an acute stroke due to large vessel occlusion, but who should not be treated, because we tend to treat almost anyone except for those who will not benefit. So we asked whether this could also be predicted, and we found the results by the software, the aspects results by the software, to be a significant predictor in the multivariate model, besides the already known factors like blood glucose level, initial NIHSS, pre-morbid state, and of course also the success of the recanalization. In a much larger patient series, my colleague Simon Nagel also could reproduce these findings retrospectively in a set of almost 1,500 patients, where again the automated aspect scores predicted the final outcome after 19 days, as well as complications like hemorrhagic transformation and also death. So back to our case. This is her aspect score, and in an automated, evaluated in an automated fashion by e-aspects, and it shows quite a good result with an aspect score of 8. And this is also why we could treat her successfully in an unclear time window, even without perfusion CT. Because what we always try to avoid, of course, is having the patient being referred to the tertiary or comprehensive stroke center, then do the perfusion CT, and then send them back without thrombectomy because it is too late. Also, these are very recent results which have just been accepted for publication, again by my colleague Simon Nagel, who retrospectively tested whether the aspect score, the automated aspect score, can be used in order to select patients for treatment even in a late or unknown time window. And what we have done here is we have separate patients into two groups, that is presenting within 6 hours after last seen well, so within the regular time window for a mechanical thrombectomy where no additional imaging usually is required, and beyond 6 hours, which included patients who presented even 24 hours after being last seen well. And we then had a look what were the differences between the groups, of course. You can see here that in the late presenting group we had more males, we had more proximal ICA occlusions, and of course we had much more penumbra imaging like MRI and perfusion CT, because this is the recommendation still to do this, and this is of course reasonable. However, when we looked at what predict the outcome, we found the typical demographical factors like age, pre-morbid state, NIHSS, the aspect score, of course the result of the recanalization procedure, so TK2B or 3, but not penumbra imaging. So even beyond 6 hours, when you have a good aspects and all the other factors are given, you can successfully treat patients even if you don't have the opportunity to do penumbra imaging by means of perfusion CT or diffusion-weighted MRI, for example. This is another case. Patient presenting, well, of course, also he was found, but he was last seen well 1 hour ago, so definitely within the time window. Was severely affected with an NIHSS of 19, And perfusion CT, at least in the qualitative evaluation, shows a clear mismatch between TTP, which we see in the upper row, and CBV, which we see in the down right corner. So, of course, we went to treat him and achieved full recanalization within 3.5 hours after last seen well. So definitely within a reasonable time window. However, it didn't benefit, and the diffusion-weighted MRI done the next day shows not only the infarction of the basal ganglia, but also a large cortical infarction in the middle cerebral artery territory. What happened? Well, when you look at the initial CTA, which is a single-phase CTA, not the often recommended dual-phase CTA, for example, you see that there are almost no or definitely significantly less collaterals in the left hemisphere compared to the right. And this can also be quantified by automated segmentation, and we end up with a TAN score of 2. However, the TAN score has only 3 items and is therefore a little bit imprecise. But what we also get is a percentage, and this is in this case, I hope it can be seen, 50.6%. So there are only half the collaterals as you would expect in a non-affected hemisphere. And this is what predicted the bad outcome in this patient when looking retrospectively. Again, back to the first case, here we now see the CTA and we see very good collaterals. This is, of course, what I withheld in the first and what was also considered when we made this decision to have this patient being referred and treated even in an unclear time window. And again, this can be quantified automatically, and we get a TAN score of 3 and get a full percentage of collaterals. A colleague of mine just presented these results at the European Stroke Organization Congress in Gothenburg this year, where we also systematically investigated the results of this automated collateral scoring, and we found a very high agree between blinded readers making the collateral scoring and the software. But of course, we will further investigate whether we can systematically predict outcome and also in which time window this holds true. To finish, I would definitely not contradict the current guidelines which recommend doing perfusion CT in a prolonged time window or in an unclear time window, because this will always add information which can be used to make the right decision in order to help the patient. However, often enough, this cannot be done in primary stroke centers, for example, before referring the patient or for whatever reason. And then we obviously still have working tools to estimate which patient will benefit, even though we cannot do the penumbra imaging, by doing the plain CT and the CTA, which we will need anyway, because we will have to prove that this patient doesn't have a hemorrhage and that he has an occluding. I have to thank not only my colleagues at the Department of Neurology and Neuroradiology at the University of Heidelberg, but of course also many colleagues at Brainomics in Oxford who enabled these investigations. Thank you very much.